You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. There are two main presentations of DKA in children: the new diagnosis, and the child with diabetes who finds himself or herself spun out of control for a variety of reasons. Today we'll talk about the broad strokes that we need to get right to take care of DKA like a boss. Melissa is a 4-year-old girl who's been to the ED already a few times this year, complaining of abdominal pain. Melissa usually gets the diagnosis of constipation. She's told to drink more fluids, take in more fiber, and out she goes. Today, her abdominal pain is back, now with vomiting. Mother says that she's been making strides in her potty training, and now she just never seems to make it to the toilet. An urgent care gave her cephalexin for a presumed UTI, but when you pressed for more information, the mother thought it was a little odd too, since they hadn't taken a urine sample. They arrive now because Mom feels that none of this makes sense and her daughter just doesn't look right to her. She now says that she just can't seem to catch her breath. And truthfully, she doesn't look that well to you either. Melissa looks tired. She's carried in by her mother. She's dehydrated and moans when you try to reposition her on the gurney. This is true lethargy. As you're getting IV access, you get a quick set of vitals. Heart rate, 166. Respiratory rate, 42. She's 15 kilos. Her mucous membranes are dry. Her lungs are clear. She's breathing rapidly but shallowly. She does not let you touch her belly. It's just too uncomfortable. Now, this could go anywhere, and of course a child with altered mental status and those vital signs and symptoms, this deserves a really nice long differential diagnosis, but you already know where we're going with this. You've seen this movie before. Her blood sugar, ready? 900. A quick VBG tells you that her pH is 6.9, PCO2 16, bicarbonate 5. No doubt about it, this child is in diabetic ketoacidosis. So let's just double check. Let's see, I know the admitting team is going to ask, what were those criteria for DKA? Hyperglycemia, defined as blood glucose over 200 milligrams per deciliter. Acidosis with a pH of less than 7.3 or bicarbonate less than 15. Ketonemia or ketonuria. Dehydration and electrolyte derangement. While you're pondering, she's looking a little bit better with a small fluid bolus on board. The other labs come back. Sodium 132. Potassium, 4.9. Chloride, 99. Bicarb on the official lab is 6. BUN, 43. Creatinine, 1.3. Her urine is all about the ketones. So let's see. Hyperglycemia, over 200? Check. Acidosis with a pH of less than 7.3 or bicarb of less than 15? Check and check. Ketones? Check. Dehydration, on exam, definitely, and BUN and creatinine are bumped. Electrolytes are a bit wacky too. Speaking of wacky, there are a lot of numbers here, and in the US we use milliequivalents per liter for sodium, potassium, magnesium, and for whatever reason we use milligrams per deciliter for phosphate. Glucose is in milligrams per deciliter, so 200 milligrams per deciliter in the US is 11.1 millimoles per liter elsewhere. Bear with me, but then again, maybe that international assignment is looking more and more tempting. We digress. Now, definitions are definitions, but these are based on a straightforward scenario. I've definitely seen patients who smolder for some time before they come to us in varying states of compensation. If you see someone who you may not think totally qualifies based on these traditional criteria, take a look at the serum beta-hydroxybutyrate. There are 3 metabolic acids that are involved in DKA. First, we have acetone, a true ketone. Next, acetoacetate, a true keto acid. At the end of a busy shift, you haven't eaten, you haven't had anything to drink, you're going to have some ketones in your urine, but it's not a big deal if you're otherwise healthy. With prolonged fasting, and we're talking a day, 2 days more, you'll see some acetoacetate that will build up in your blood. And again, by itself, this may be caused by various things. In the context of DKA, of course, it's starvation on a cellular level. Both acetone, which is usually expelled via your pulmonary circuit, and acetoacetate, which is expelled in your urine, both are what the urine will pick up as ketones. Their sensitivity is in the 90s, but their specificity is in the low 30s. Did you just not have anything to eat at all today, or are you in DKA? That's why the specificity is low. However, hydroxybutyric acid is the third acid that is involved in the disruptive metabolism that we find in DKA. It's not detected in the urine because it's a hydroxy acid. It's the byproduct of free fatty acid metabolism. Your body needs glucose. Your brain thrives on it, although it can still very poorly use some fatty acids. Your heart can use either. Proteins can be broken down as fuel as well. However, your body vastly prefers running on sugar, right? Now, I looked into this, but caffeine has not yet been proven to be an essential fuel for the body. I'm sure that our technology is just lagging behind in our evidence for that. Anyway, once glucose is not available to the cell because of the lack of insulin, free fatty acid metabolism kicks in to fuel the heart and sort of poorly fuel the brain. The main product is, you guessed it, beta-hydroxybutyric acid. Its sensitivity is just the same as the other ketones, so as high as 98%, but the specificity of beta-hydroxybutyric acid is the most helpful. It's in the 70 to 80% range, much better than urine ketones. I go through all this to mention that someone may be smoldering on the teeter-totter, back and forth, in and out of DKA. Or they may have a hyperosmolar state, say in the older adolescents that have a higher BMI, or adults. Maybe they have type 2 diabetes and their pancreas just starts to poop out. Anyway, all it takes is a wee bit of the insulin to stop ketosis. Or maybe your urine is very dilute because of the osmotic effect. You may not see ketones initially. Or maybe your pH is still not quite as bad to not quite meet criteria. You've been clicking and clacking in and out of free fatty acid metabolism, so your beta-hydroxybutyrate is the only ironclad proof of what you've been suspecting this whole time, DKA. There's actually mounting research that we should start using beta-hydroxybutyrate as a criterion standard, but so far it just will remain my unofficial advice to you. When in doubt, you're unsure, the patient, you would be so surprised if they did not meet criteria. They don't. Check that beta-hydroxybutyric acid. It's just as sensitive as the ketones, but even more specific. Now, while we're on the subject of criteria, specialty societies have slightly different cutoffs among them and between adults and children. As we go forward, we'll try not to get stuck on technicalities or precise numbers. Instead, we'll first use our clinical history and then our exam to spark a suspicion of what may be going on, and we'll use our lab tests to help us to confirm. Cutoffs are cutoffs, and remember, they're man-made. Just because your glucose is 199 doesn't mean you don't have DKA. We want, ideally, all three parts: the diabetes, the ketosis, and the acidosis. But sometimes the latter two are just not so apparent. More on that later. In Melissa's case, this is a slam dunk. There are definitions of mild, moderate, and severe DKA based on the pH and the bicarb, but for our purposes, it's not as important. Really, we're going to be doing the same things for the patient, whether they have mild DKA or severe DKA. It's all going to be based on the clinical presentation of the patient and not necessarily the numbers. Remember, it's all about the patient in front of you and the context of the presentation. All right, you've made the diagnosis of DKA. We still have to figure out the why of DKA. Why did this patient go into diabetic ketoacidosis? Traditionally, we think of the 3 I's of DKA: insulin, infarct, and infection. Let's add another and make that 4: insult. So, insulin, infarct, infection, insult. Insulin, not enough, of course. In type 1 diabetes, they simply don't have enough. They're not making any. And if they're getting behind in their meds or not taking them at all, or if they leave their insulin out of the refrigerator for more than a month or store it in a hot place, that can cause trouble. In Melissa's case, we're making this diagnosis initially, and the patient and the family are going to need a lot of wraparound services. This is a life-changing event. But maybe you have the teenager who is trusted a little too much with his medications, and he loves candy and not checking his blood sugars even more. Infarct. Now, this is often an adult thing, but we think about MI, stroke, mesenteric ischemia. Children can get those things too, but luckily not too often. Infection. Anything from a simple cellulitis to pneumonia to UTI is enough to throw that child into diabetic ketoacidosis. And lastly, my addition, insult. Really, this is an excuse to keep your mind open to think about anything that can cause an increase in physiologic or metabolic demand or upset normal homeostasis. Pancreatitis, trauma, pregnancy, some medications. Use this last one not as a grab bag, but to keep your mind open to any of these possibilities, and also the opportunity to really dig deep into the history and talk to collateral sources to figure this out. Because, well, the child is just not going to recover completely until we figure out the causative agent. Let's get cracking. IV access, resuscitation, chemistries including calcium, magnesium, phosphate, pregnancy test, EKG. The EKG may be the first window into the patient's metabolic derangement, and you'll be glad you got it. Clinically relevant hypokalemia or hyperkalemia. All right, hyperkalemia with peak T waves, or hypokalemia with flattened T's and even U waves. The acidosis itself will prolong the QT, so careful when you're giving antiemetics like ondansetron, for example. A quick EKG can keep you out of trouble and will be available to you really very swiftly before the rest of your chemistries come back. Now, what about the other life threats in DKA? The most obvious, of course, is the hyperosmolar dehydration that you see right in front of you. This patient needs resuscitation. Dry mucous membranes, tachycardia, confusion, drowsiness, these are all the ways that we can make that assessment. The ketosis and acidosis you'll see as tachypnea, trying to blow off as much CO2 as possible to compensate. The acidosis causes nausea, vomiting, abdominal pain. Unfortunately, often the new diagnosis of type 1 diabetes will be DKA, especially in the less than 5-year-old crowd. The symptoms are so vague initially. Children are not so communicative. It may just look like constipation or viral syndrome or gastroenteritis or many more mimickers. The take home here, I think, is that if you see a young child who looks sicker than what your presumptive diagnosis may suggest, just do a fingerstick glucose and see where you stand. You'll catch diabetes earlier that way and hopefully prevent the later presentations of DKA. We talked about the misdiagnosis of gastroenteritis without the, enteritis part. Lots of vomiting without diarrhea. That's a red flag. Or the child with excessive urine output who is dehydrated. Those two do not fit nicely under a stomach bug or just a hot day outside. Respiratory distress with clear lungs should also be an alarm bell. Okay, now, I'm going to tell you it's all about the clinical signs and symptoms, but we need to do some math here. I know, I didn't make the rules, but just trying to keep us both out of trouble. Let's dabble in Winter's formula. First, I can never remember this. I'm just trying to be real with you. I have to look it up, and I'm okay with that. We do need to know how to use it, though. Winter's formula is used to uncover what should be the normal compensation for metabolic acidosis. It's sort of a double check mechanism. The PCO2 should equal 1.5 times the serum bicarbonate plus 8, give or take a little bit. If we plug in Melissa's numbers, we find that her expected PCO2 should be 1.5 times her bicarb of 5 plus 8. That ends up being 15.5, give or take 2. This checks out because her measured PCO2 is 16. So Winter's formula agrees with what we have measured. There's no other crazy hidden things here. She's compensating for her ketosis by trying to blow off that CO2. I mean, we see her do that right in front of us with her Kussmaul respirations. But what if her actual measured PCO2 is higher than what the Winter's formula would predict? That means that she's slowly losing that battle of blowing off CO2, and now she's retaining it, getting sicker. By the way, what are Kussmaul respirations anyway? They're named after Adolf Kussmaul, a German physician in the 1800s. In early mild metabolic acidosis, the patient breathes rapidly and often shallowly to compensate. As the acidosis worsens, the patient tries to compensate by ventilating more, so he takes deeper, more labored breaths. It becomes almost gasping. This deep, gasping breathing is called Kussmaul Respiration. It's kind of a funny coincidence that Kuss in German means kiss, and Maul is an impolite word for mouth, like someone's mug or the mouth of an animal. So Kussmaul literally means kissy mouth. And now you won't forget it. Bitte verzeihen Sie mir, Herr Dr. Kussmaul. You know that you have to resuscitate this child, but you also know the general mantra of emergency medicine. The tempo of treatment should match the tempo of disease. It took Melissa some time to get here. It's going to take her some time to get better. So you start at 10 ml per kilo bolus, knowing that she's going to need much more than that, but you wonder how much and how fast should I give it? Our goal, number 1, is to resuscitate. If there's shock, don't think about anything other than to get that child out of shock. But after that, we need to be careful about correcting the dehydration, the acidosis, the ketosis, and the hyperglycemia. We do that with careful fluid resuscitation, with insulin, with repleting electrolytes, and cardiopulmonary monitoring. What we leave out of our algorithm sometimes is the very important checklist item, avoiding complications. Not to beat around the bush, but cerebral edema. There, I said it. Up to 1% of children with DKA will experience it. You will see it. And when you do, the mortality is up to 25%. Those who survive it may have cognitive impairment. And it's a favorite thing for lawyers to go after. Brain swelling. Insert magical thinking and you get, aha, the emergency physician pumped the child full of fluids and now the child's brain is full of the fluids. But not so fast, Sparky. First, let's talk about who gets cerebral edema. Based on case control studies, Those at highest risk are those under 3 years of age who have had DKA in the past, a pH of less than 7. Also, lab findings like an elevated BUN, low PCO2, and a glucose above 1,000. Those are all correlations with terrible diabetes and, of course, cerebral edema. The traditional and limited understanding of cerebral edema and DKA was based on the cytotoxic model, where fluid shifts occur with treatment, causing swelling of neurons, coma, and death. This is where the lawyers love to say, aha, fluid on the brain, you did it to them. We know now that cerebral edema and DKA likely follows more of a vasogenic model. Ketone bodies likely act directly on the brain's microvascular endothelium, causing the edema. Beta-hydroxybutyrate and acetoacetate stimulate the production of vasoactive peptides, causing further leaking, no matter what you do. Dr. Glaser et al. In Pediatrics used diffusion-weighted MRI to quantify edema formation during and after treatment in children with DKA. It's really an amazing feat to get 2 MRIs done in the ED within hours of each other. They measured the apparent diffusion coefficient of brain water to see if there was indeed this fluid shift that the lawyers would love to look for. It turns out, no. The degree of edema formation during DKA in children is correlated with the degree of dehydration and hyperventilation at presentation, but not with factors related to osmotic changes that may occur during treatment. The authors concluded that cerebral edema is related to cerebral hypoperfusion during DKA, so the opposite of what was traditionally believed. Osmotic fluctuations during DKA treatment do not play a primary causal role. It's been shown that many children have subclinical cerebral edema on presentation before you even say, "Hello, my name is." This data is very satisfying, but it's also very theoretical. Luckily, the same researchers took it a step further and finally answered the clinical question: what fluids and how fast should we give them? Now, before the PCARN study that we'll talk about, we withheld our normal treatment, and it didn't make sense. I felt bad about it. We knew these children were multiple liters down in fluids, but we withheld. We really were very stingy with our fluids. In adults, a patient gets 2, 3, 4 liters of NS without batting an eyelash before we even know what their chemistries are. Why did we treat children differently? Why did we worry about not giving them enough fluids when they clearly needed resuscitation? Before, we would keep them little raisins and then slowly over time rehydrate them with 10 mLs per kilo, then maybe another, slowly replacing the deficit over 48 hours. Some would use NS, some use 1/2 NS. It was all over the place. Cooperman et al. In the New England Journal of Medicine in 2018 published a clinical trial of fluid infusion rates for pediatric diabetic ketoacidosis. This was a randomized control trial, a 2x2 design. 1,389 children with DKA were enrolled in 13 centers over 5 years. All received the standard 10 ml per kilo NS bolus. After this, subjects were randomized into subsequent fluid administration, slow or fast, NS or 1/2 NS. The fast groups got a second 10 ml per kilo bolus, either NS or 1/2 NS, and a replacement of 10% of body weight, half over the 12 hours, the second half over the next 12 hours. The slow group got no second bolus. They received replacement of 5% of body weight evenly over 48 hours. So 2x2, 4 groups. The primary outcome was deterioration of the neurologic status in the first 24 hours. All subjects started with a GCS of 14 or 15. Are you ready for this? There was no difference between the groups in decline of neurologic status. This is a big win. Secondary outcomes like short-term memory during treatment and long-term neurocognitive outcomes, no difference. There are actually trends favoring fast repletion. So what does this tell us? Treat the shock. It's okay. Treat the hypovolemia. If you need to, give that 20 ml per kilo bolus. You should never feel bad about giving anyone a 10 ml per kilo bolus. Remember, when it comes to a fight between volume and osms, volume always wins. Okay, you've diagnosed the DKA, you're treating the shock, you're repleting fluids and electrolytes, you're feeling like a boss. What about insulin? Not so fast. Before we start insulin, we have to know the patient's potassium. Most patients will be profoundly depleted in potassium, but you may find the odd bird here or there that has hyperkalemia. As soon as we start the insulin, the potassium will be driven into the cells, so we have to be prepared. If the potassium is less than 3.3, then you must replete the potassium up to or beyond that level before you give insulin. Hypokalemia kills. You have time. Replete the potassium while you give IV fluids, recheck the potassium, and continue to give potassium while you start insulin. If your initial potassium is between 3.3 and 5.5, then you may start insulin while you continue to give potassium. Remember, they are total body down in their potassium stores. And also, an acidemic environment may show a falsely elevated potassium. So even your measured potassium is probably a little bit of a false reading. As soon as you start to correct that acidosis, it'll drop just in and of itself. But of course, the sodium-potassium glucose pump will then cause your potassium to drop even lower. It's going to take a dive once you start the insulin, so you need to replete on a continuous basis and check electrolytes every 2 hours. The only time that you'll be giving insulin alone, without potassium, is when the potassium is obnoxiously high, greater than 5.5. Keep checking your chemistries every 2 hours because you can be fooled later on, and again, they're probably going to end up needing potassium anyway. Now, here's an important tip, or at least a reminder. Hypokalemia almost always goes hand in hand with, hypomagnesemia. Make sure you're repleting your magnesium with your potassium. The hierarchy is, after fluid resuscitation, potassium is priority, start insulin with or without potassium, and as all of that is stewing, just make sure that at some point you either address the magnesium level or just go ahead and supplement. You can never really fully replete potassium without its cation co-partner in crime, magnesium. Okay, you've checked and repleted like a boss. It's safe now to start the insulin. Let's get into it. Insulin boluses are out. The theory of priming the receptors is not worth all of the technical errors it will cause. Just start that drip of regular insulin at 0.1 units per kilogram. You may adjust this slightly depending on the patient's comorbidities, but it's a good place to start and you won't hurt the patient this way. Remember, insulin is based on actual measured current body weight, not ideal body weight. Everyone gets 10 mLs per kilo NS before you start that insulin drip. You're going to want to know what the glucose level is after you give that bolus. There's also an association with poor outcomes with starting insulin before starting fluid resuscitation. Now, that child's glucose may drop quite a bit, and you'll want to know that what that fingerstick glucose is before you start the drip. You're going to base it on that, whether they need supplementation or not. So start the fluid bolus while you're waiting for your chemistry panel. Verify the glucose, verify the potassium. Remember, if it's below 3.3, you replete the potassium before you start the insulin drip. Recheck the fingerstick glucose after the bolus and before you start the insulin drip. This way, you know your initial potassium and the post-bolus glucose before you start the insulin drip. All right, diagnosis, fluids, insulin, potassium, admit to the PICU, done, next patient. Not so fast. This is where your critical care skills come in handy. Critical care is not just the tubes, lines, and high fives. That's just the beginning. Once you've plugged the hole in the sinking ship, you have to keep bailing the water out and look for other cracks. Phosphate is often overlooked, and that can be deadly. It usually starts with just forgetting to check the phosphate level. Phosphate is already dangerously low in the acidemic state, but we have a little bit of a safeguard here. Since there's a lack of insulin in type 1 diabetes, the patient is in more of a catabolic state. The body can't use the glucose flying around because of the lack of insulin, so it tries to eke out some metabolism from lipolysis or proteolysis to try to compensate. If we give insulin and sugar, the normal treatment for DKA, without thinking about phosphate, we can cause a lot of problems acutely. Now, you've got plenty of substrate, the glucose. The patient is profoundly hyperglycemic. You give the insulin, the key to unlocking metabolism by the cells. And by the way, what's the whole point of all of this? It's to produce cellular currency, ATP. Adenosine triphosphate. You have a nitrogenous base, adenine, a sugar, ribose, and not mono, not di, but triphosphate. Once you start making ATP by matching up glucose with insulin, phosphate levels can drop precipitously. So what? What has phosphate done for you lately? Well, for one, it keeps your heart beating. Phosphate levels below 1.2 are dangerously low, and below 1 are associated with spontaneous cardiac arrest. If your patient with an acidemia arrests for any reason, you're going to have a hard time getting him back, especially since phosphate repletion takes so long to do. The moral? Prevention. Check that phosphate early and replete. Now, how do I do that? At some point, you may be saying, look, Tim, this patient is probably already admitted and the PICU will have their own way of doing things. And that may be true or not. We have to know what we need to know and a step or two beyond that. So there are variations to this, and you should follow your institutional protocol or take a look at the show notes. Many pediatric centers will use a 2-bag system, often with an IV fluid bag, number 1, containing say NS with potassium phosphate, potassium acetate. These children almost always are hypokalemic and hypophosphatemic, as we talked about. Bag 1 is, think of it as the basilar rate bag. It's ongoing while the insulin drip is running. Bag 2 may be on or off, or will change the rate depending on the child's glucose or fluid requirements. Once the glucose falls below 300 and the gap isn't closed, if you're still acidemic, you'll need both ongoing insulin and more glucose. Instead of stopping all the fluids and supplements, you can simply turn off bag 2 as it supplements bag 1. Bag 2 may be also where you fine-tune the amount of sodium the child is getting. It may seem a little bit complicated, but when you're juggling the repletion of fluids, insulin, potassium, phosphate, glucose, it's nice to have a little bit of control. Bag 1 is your basilar rate that you'll always need. Bag 2 will have various supplements depending on the child and what he needs at that moment. Now, it gets technical because we're combating a few simultaneous perturbations all at once. First, there's the obvious anion gap acidosis. Acetoacetic acid and beta-hydroxy butyric acid will dissociate, and they'll produce lots and lots of hydrogen ions. Your body's bicarbonate buffer will struggle to keep up, but at some point it can't. For each anion produced, there is a loss of one bicarbonate. Then there is the mounting hyperchloremic acidosis that we can give the patient when we overdose them acutely on normal saline. This is why a lot of people like to use lactated ringers or anything isotonic that's balanced. Also, another concurrent problem in diabetic ketoacidosis is the lactic acidosis from hypoperfusion and the ensuing anaerobic metabolism. Also, add on to that a metabolic alkalosis from lots of vomiting, Add on to that a respiratory acidosis from a depressed mental status, and add on to that a respiratory alkalosis from sepsis or abdominal pain. So there are so many ways that DKA can mess you up. This is why sometimes the formulas don't seem to add up initially, and why our meticulous monitoring of electrolytes and repletion is so important. It turns out your body needs insulin, well, for almost everything. One last little side note. You will often see patients in DKA, or really in any hyperglycemic state, with pseudo hyponatremia. The osmotic effects of hyperglycemia draw water into the vascular compartment and create a dilutional hyponatremia. It's a weird term because, on the one hand, Melissa's sodium of 132 is actually the current sodium concentration that her vascular compartment is seeing right now. But we know that as soon as the hyperglycemia is cleared and the dilution resolves, the sodium is actually going to be much higher, and this may be more apropos to the type of ongoing IV fluids that you give the patient. The formula proposed by Katz et al. In the 70s is the one that we still all know and love. For every 100 milligrams per deciliter of glucose above 100, we'll add 1.6 milliequivalents per liter of sodium. So Melissa's measured sodium on arrival was 132. Her blood sugar, 857. So I kind of like to think of this in blocks. The first 100, okay, pass. From 100 to 200, add 1.6. 200 to 300, add another 1.6. In other words, from 100 to 857, there are about 7.5 blocks of 100 that she should be corrected for. So 7.5 times 1.6 is 12. So we'll add 12 to her current 132, and we'll end up with a sodium of 144. So even though it looked like she was slightly hyponatremic, with correction, her sodium is actually 144 milliequivalents per liter. As her glucose falls with treatment, we'll expect to see a sodium closer to 144. So careful with too much normal saline. One quick note about bicarbonate. You may see a very sick child in front of you. You may think, wow, that pH is terrible, and the patient looks horrible. So let's just fix him up right now with a little yin for that yang. No problem. Not so fast. Bicarbonate administration is not indicated in pediatric DKA. It's not a simple repletion. It's a complex buffer system. You can't just override it. The best thing that you can do to restart your buffer system and get out of the acidosis spiral is to restore the patient's circulating volume. This will improve tissue perfusion and get your kidneys working again. Our kidneys are much smarter than we'll ever be, and they just need some priming of the pump to do their job. Now, you may think this child is really sick. Bicarbonate, who knows, maybe it'll help. What's the downside? Oh, ho, ho, there is a major downside to giving bicarb DKA. Your CSF is doing its best to protect itself from the acidemic environment with its own buffer system. If you fool it by falsely artificially correcting the peripheral serum pH, your central CNS compartment lets down its guard, and you cause a paradoxical central nervous system acidosis. Also, if you just push some bicarb like a troglodyte, this itself will cause hypokalemia and possibly enough to cause arrest. In other words, no bicarb for you in DKA. Just don't do it. The same goes for intubation. The child is blowing off CO2 faster and better than you could ever do mechanically, even when altered. Endotracheal intubation for DKA should never be done electively. If the child arrests, all bets are off, but otherwise, bicarb and endotracheal intubation are what you do when desperation time is over and you're just flailing. But you may think, wow, this patient seems to be in increased work of breathing, and it probably is from the acidosis. One nice thing you can do for them is to give them high-flow nasal cannula. That will make them more comfortable, it'll help them to ventilate, and it'll just help them to do what they're trying to do anyway, but you're not overriding the patient whose CNS is still smarter than you are. All of this we do and torture ourselves with to make sure to avoid the complications of DKA, or at least mitigate them the best we can. We talked about the dreaded cerebral edema and that fluids don't cause it. Sick children get cerebral edema and sick children get fluids, but correlation is not causation. But what do you do if you see a child whose mental status is deteriorating? Now, I don't want to say that we know exactly why one child has cerebral edema and the other doesn't, or how much of this is vasogenic versus cytotoxic. It doesn't matter. It's going to happen or it won't. If you see a decline in concentration, attention, level of consciousness, you have to react and assume cerebral edema. Don't wait for a head CT to start treatment, or don't wait until the child worsens with Shane Stokes respirations. Remember, cerebral edema is a clinical diagnosis. Treat it early. Mannitol is the drug of choice for the treatment of cerebral edema. It lowers blood viscosity and improves cerebral blood flow and oxygenation. Most importantly in cerebral edema, mannitol has a direct osmotic effect and reduces extracellular free water. Give 1 gram per kilogram IV over 10 to 20 minutes, and you can repeat that in 1 to 2 hours if you need to. Hypertonic saline is also an option here, and its mechanism is mostly extrapolated from research in head trauma. Now, you still may be tempted to intubate if you have a declining mental status and cerebral edema. If the patient truly has respiratory compromise, then by all means, do what you need to do and secure the airway. I will tell you that even in the sickest patients, this is not always needed. Jim Marson et al. In the Journal of Pediatrics in 2002 showed that aggressive hyperventilation was a significant risk factor for poor outcome, of course, in addition to all of the acid-base buffering chaos that we talked about with CNS and intubation. Cerebral edema from DKA is a different clinical animal than cerebral edema from traumatic brain injury. I see the same altered mental status in 2 pediatric patients with cerebral edema, and one's because of TBI and the other's because of DKA. That TBI is going to get tubed because he's going to benefit from the intubation. The DKA is getting treated with mannitol and watched like a hawk. He doesn't necessarily benefit from endotracheal intubation. In fact, we may put him in more dire straits. Other complications to watch out for, of course, are renal failure, pancreatitis, rhabdomyolysis, and superinfection. DKA is a hypercoagulable state, and DKA stroke may look a lot like a cerebral edema. So it's complicated and difficult. Don't go looking for focal findings for stroke and say, aha, they are generally depressed. In one case series, only 8 of 28 children with DKA stroke had focal findings. So the take home here is, if you suspect cerebral edema in DKA because the child's mental status is worsening, then you just treat it. But you also look for improvement, and if he's not improving like it should, of course you're going to continue the cerebral edema mannitol treatment, but you're going to get that head CT when you can, especially if that child is worsening or not improving. Luckily for us, Melissa looks better and her vital signs improve even after the first normal saline bolus. You are careful with her electrolytes and make sure she's carefully monitored. It's a first diagnosis for the family, so there's a lot of adjustment and education, but the family's very grateful that you took excellent care of her and didn't just go with constipation. Let's take this home. The definition of DKA is hyperglycemia, defined as a blood glucose of over 200 milligrams per deciliter. Acidosis with a pH of less than 7.3, or a bicarbonate of less than 15. Ketonemia or ketonuria, dehydration, and electrolyte derangement. Everyone gets 10 mL per kilo NS bolus, and likely more as needed to resuscitate those who happen to be in shock. We need to know our potassium and phosphate levels, in addition to an updated glucose, before we start the insulin. Any child can develop clinically apparent cerebral edema, and it's more likely in preschoolers and young children, so be extra careful with them. Treat with mannitol, and remember the multi-organ system involvement that can complicate DKA. And after all of that, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.